Okay, hey guys. We're going to do chapter 23, behavioral health emergencies. We've talked about a lot of this already. So we're going to cruise right on through. Here we go. Um, so we're going to work on recognition of behavior that poses a risk to the EMT patient and others, basic principles of mental health, assessment and management of acute psychosis, suicidal risk, and agitated delirium. So to get started here, the EMT often cares for patients' experience behavior, um, health emergencies. Sorry, my phone was going off. Crisis may be the result of an acute medical situation, mental illness, mind-altering substances, stress, other causes. So you're going to hear in this lecture or in these slides, don't just jump to a conclusion. Don't just assume things. Um, a lot of this stuff can happen to perfectly normal, everyday people. So we really need to work on getting our history, studying our scene, making sure everything adds up and we get that big picture before we just jump to conclusions. At some point, most people experience these emotional crises. This does not mean that everybody develops mental illness. Well, there you go. Don't jump to conclusions. The most common misconception is that if you are feeling bad or depressed, you must be sick. There are many justifiable reasons to feel depressed: divorce, death of a relative or friend. You're going to hear me if you haven't already throughout this course. Really preach or lecture or whatever you want to call it about well-being as a EMT, advanced EMT, paramedic, EMR, whatever you are. Um, because we do go through this. We go on calls that we're not, our brains aren't meant to see. We hear things we're not, that never go away. Um, so I really push towards taking care of ourselves. But it's a really good example that even people trained to deal with stuff have problems. So imagine these people that aren't trained. Imagine that bystander that comes across that car wreck, or that wife that actually codes her own husband or child or something like that. It's going to play a psychological effect on the person. So always keep that in mind. Some people believe that all individuals with mental health disorders are dangerous, violent, or unmanageable. No, only a small percentage fall into that category. EMTs may be exposed to higher proportion of violent patients, which is true. Communication is key. You may be able to predict violence, which we're going to talk about. So, behavior is what you can see of a person's response to the environment, his or her actions. Over time, people learn to adapt to stress in their own way. Sometimes stress is so great that the normal way of coping doesn't work anymore. Reactions to stress are acute and those that develop over time can create crisis. Sometimes it's important to gain information. What is normal for the patient? Normal is different for each of us, so keep that in mind. My normal and your normal are two different things, I promise. Um, Once again, gain that information, find out what that person's normal is, and don't judge it because it's not the same as you. Behavioral crisis includes patients who exhibit agitation, violence, or uncooperative behavior, or who are a danger to themselves and others. I think that's pretty cut and dry. If an abnormal or disturbing pattern of behavior lasts for a month or more, it's a matter of concern. When the behavioral health emergency arises, the patient may show agitation or violence, may become a threat to themselves or others. Magnitude of mental health disorders. Uh, Mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological and or behavioral symptoms that may result in impaired functioning. Anxiety disorders are among the most common. Anxiety disorders include generalized anxiety disorder, panic disorder, social or other phobias, um, postpartum stress disorder, obsessive compulsive disorder. The U.S. mental health system provides many levels of assistance. Professional counseling are available for any pretty much anything. Um, let's see, more serious issues often handled by psychologists. Several psychological conditions require a psychiatrist. So, once again, there's help out there. Um, we are the advocate for that patient. So if we can suggest as we're on our way to the hospital, hey, I know of this place that helps with this problem. Um, it just depends on the call. It depends on the patient, but there is help out there for these people. So don't just like throw in the towel and give up on them. Most psychological disorders can be handled through outpatient visits. Some people require hospitalization or specialized behavioral health units. Sometimes it's just medications aren't agreeing with them. Sometimes, they went through so much stress and trauma in their life that something snapped. Uh, they're just going through a really, really bad time right now. So don't judge, offer to find that help, and be patient. Behavioral health disorders have many underlying causes: social and situational stress, disease such as schizophrenia, physical illness such as diabetic emergencies, chemical problems such as alcohol or drug use, biological disturbances such as electrolyte imbalances. So, just real quick, just so we can kind of tie things together, physical illnesses such as diabetic emergencies. Yeah, because diabetes causes altered mental status, correct? It doesn't always just make you pass out. What about a stroke? Can a stroke affect someone's mental ability, stability, I guess? Definitely. You can take the nicest person in the world, they have a serious stroke, and now they cuss more than a sailor and they hate the world. So medical things can lead to these psychological. It's not always just they're crazy. Um, Alcohol and drugs, especially the drugs, but what about DTs? Been a drinker for 40 years and now we've quit cold turkey. Can that affect someone's mental well-being? Absolutely. They can become violent. They can become emotional. So just keep those kind of things in mind. I am a broken record. Get the history. Ask the question. If you even think, "Oh, I wonder if this person used to drink a lot," ask them. That's our jobs. That's what we do. An EMT is not responsible for diagnosing the underlying cause of a behavioral crisis emergency. You should understand two basic categories of diagnosing or diagnosis a physician will use is organic and functional. I know I just said try to get information and figure this problem out. I'm not telling you to diagnose. What I am telling you is to gain the history so that we can start down the right road. I don't want anybody thinking that I'm saying, diagnose the problem. Get the history, build that puzzle so you can see the big picture. So let's talk about organic disorders. Organic brain syndrome is a temporary or permanent dysfunction of the brain caused by disbalance, disturbance, sorry, in the physical and psychological functions of the brain tissue. So the causes can be like sudden illness, traumatic brain injury, which is a TBI, seizure disorders, drug and alcohol abuse, overdose or withdrawals, and diseases of the brain. Organic disorder, altered mental status, can arise from hypoglycemia, hypoxia, impaired cerebral blood flow, hypothermia or hypothermia. Functional disorder, um, physiological disorder that impairs bodily functions when the body seems to be structurally normal. Examples is schizophrenia, anxiety conditions, and depression. Okay. Safe approach to behavioral crisis. I might get on a soapbox here. I don't know yet. We'll see. All regular EMT skills are used in a behavioral crisis. Definitely. So this is a big one. Scene safety. Is the situation potentially dangerous for us or and our partner? Um, do you need immediate law enforcement backup? Should you stage until law enforcement personnel have secured the scene? Yes, 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 and no. I mean, it depends on the call. If we believe that there is any type of threat towards us or our partner, absolutely call law enforcement. Um, Sometimes we just don't know though until we're there. At that point, yeah, we can get out of there, we can back out. Uh, these patients, you might actually get to know, they might become kind of regulars. So we might know what we're walking into. It's just it depends on the call, honestly. Point being, always make sure that it's safe for you and your partner, and then we worry about the patient. Um, if this is someone that I know I've been on and they're always wound up tight and they could pop, or they might be emotional or they might be angry, it just depends. I'm going to go ahead and call law enforcement. I'm going to have them meet me on scene just so I have some backup there. Does the patient's behavior seem typical or normal for the circumstances? Keep that in mind. Um, are there legal issues involved, like a crime scene, consent, refusal? Take standard precautions, always. We always do that. And let's request an additional resource early. So, does the patient behavior seem typical or normal for the circumstances? That's what I mean by it depends on the call. Um, if it's the death of a child or a loved one, I'm expecting them to be screaming and crying or being mad or being emotional. I expect that. Traumatic or fatal car crash. I expect some chaos. It's normal. Um, if I'm going for I stub my toe at 3 in the morning and I walk in and that 6'5" guy over there looks like he's just madder than can be, because his wife woke him up because she stubbed her toe. Now I'm gonna worry. Now I'm gonna read body signs, which we're gonna get into that here in a minute. But whole point is what is normal and how would you feel in those circumstances, I guess. Mechanism of injury or illness. Determine the mechanism of injury or nature of illness. Note any medications or substances that may contribute to the complaint or be treatment of a relevant medical condition. We always get medication list anyway, right? That's part of our history. Um, Study the scene, which I know we've talked about this 1,000 times. As we're entering a scene, as we're entering wherever we're going, we want to almost scan that room and take snapshots in our mind. We're just screenshotting that room or that scene in our mind. And we're looking for anything that indicates what might have caused this, what can cause further problems. Like I've said before, our scene is never 100% safe because we cannot pause time. When we walk into a house, we cannot just pause time and everything sits still. There's always motion around us. So we need to screenshot everything. We need to take all that in and pay attention, whether that be out on a highway and we see fluid leaking out of a car, or whether we walk into a house and we notice a gun sitting on a shelf. Those are things that we have to notice when we get there and pay attention to. Um, Form a general impression. So begin your assessment from the doorway or from a distance, which is what we just talked about. Perform a rapid physical exam. Observe the patient closely using that AVPU scale to check for alertness. Establish a rapport with that patient. Most medical and trauma situations will include a behavioral component, which we've kind of hit on. There's always going to be some sort of emotion. There's going to be some sort of behavior, whether it be sadness, anger, depression, uh, blaming. It might be someone else's fault. It might be our fault. It's to them. They feel that way. Um, so just be ready for that. Establishing rapport. We need them to trust us. We need to walk in there as professionals. We need them to see us as professionals, and we need to continue that. We need to be able to read people, read the room. What's okay to say? What's okay not to say? Um, and you're going to learn this out there in the field. There's scenes where I can joke around with my patient or the family, and it's perfectly fine. It relaxes everybody. And then there's scenes where you've got to go in, you've got to be on your A game, and everything is serious, and there's, no smiling, no joking, no. It just depends on the call and you reading the scene. Airway and breathing. Assess the airway to make sure that it is patent and adequate. So, hey, is my airway open or do I need to open it? Is my patient breathing? Are they breathing normally? Are they working to breathe? What's my rate and quality of that breathing? Do I need to put interventions in? Do I need to open that airway using an adjunct? Do I need to use a BVM? Do I need to, use that non-rebreather? Uh, so we go through those steps on every single call. We are constantly using those skills, just like we're learning in class. We use those every call. Circulation. So assess the pulse rate, quality, and rhythm. Do I have a pulse? What's it like? Is it strong? Is it weak? The rhythm, is it regular? Is it regularly irregular? Um, evalu- uh, Evaluate for the presence of shock and bleeding. Look for that pale, cool, clammy skin. Check that cap refill. We are going to be reassessing these every either 5 minutes or 15 minutes, depending on the call. Um, are things changing? Why are they changing? Transport decision. So do I want to stay and play or do I want to let them go? Unless the patient's unstable from a medical problem or trauma, prepare to send or spend time with that patient. If there are no life threats and that patient is stable and they are okay, we're not in a mental crisis, no one's dying right now, yeah, we stay and play. That's what we go to school for, right? So that we can use our skills. Now the other side of that, if there's something going on and it's bad, then we load and go. We can do work in the truck also. We don't have to do it right there in the field. History taking, I know I've kind of beat this dead horse, but we're going to keep beating on it. So investigate that chief complaint and obtain your sample history. Consider four major areas as contributors. Is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Are significant life changes, symptoms, or illnesses involved? Is there a history of behavioral health issues or illnesses? Um, because every one of them is going to play a role in how that patient reacts to us and how we interact with that patient. That sample history, uh, you may be able to um, get that information. That would be helpful to the hospital. In geriatric patients, consider Alzheimer's disease or dementia. Use reflective listening. So we kind of say it back. Remember sample, signs and symptoms, allergies, medications, past partner history, last oral intake, and events leading up to. If you don't have that pounded in your head yet, you will by the end of this course. Um, Questions to ask. I'm not going to read all these. Uh, like I said earlier, if you feel like asking a question because something is telling you that that might be the case, go ahead and ask that question. It's not going to hurt anything. Physical examination. In an unconscious patient, begin with a physical examination. Why are they unconscious? We got to figure that out. A conscious patient may not respond to your questions. That's perfectly normal. We do the best we can. We use bystanders, family, whatever. We collect those medication bottles. Maybe that's an indicator. Maybe that tells us something. How much medication have they taken compared to what's supposed to be in the bottle? Read the room. Look for signs. What could be causing this? Not making this up. I've been in houses where there's literally a bag of meth on the counter and crack pipes, or there was a bowl of marijuana that they were actively like crushing up so they could roll it up. Those are the kind of things we need to look for. Um, Insulin syringes. Um, I've already said medication bottles. Just be very open to looking for those things that might just point us in the right direction. Physical examination, you can tell a lot about a patient's emotional state from facial expressions, pulse rate, respirations, a blank gaze or rapidly moving eyes could mean central nervous system or dysfunction. Once again, read your patient. Transportation decisions again, have law enforcement or firefighters accompany you if possible. There may be a specific facility to which patients with behavioral health emergencies are transported. Transport by ground. Make the patient comfortable. We're talking about, mental things. We want that patient to trust us. We want that patient comfortable. We want to keep them calm. We want to keep them communicating with us. Um, Nothing against our fire or police. Sometimes that will actually elevate a patient's aggravation. So I'm not telling you not to put law in the back of the truck. I'm 100% for having extra people back there. Sometimes it might be best if your protocols allow it or your facility allows it. Let the firefighter drive and two medics be in the back. But if we're dealing with someone with psychological problem or they're psychotic or whatever, we definitely need two people in the back. It protects us. It protects that patient as well. The whole point of that, though, is um, I've actually, when people are in these states mentally, that little star life we wear on our chest, they see that as a badge. They see that as, we're out to get them, just like a police officer. They see a fireman, they're an authority figure as well. They will immediately go on defense. So it's very important that we are the calm ones, that we are the quiet ones, that we talk with respect, that we make eye contact when they're communicating with us. Because as the medical personnel, they don't realize they need us. And some if we start off combative towards their attitude, we're not going to get anywhere with these patients, and it's going to turn into a lot messier scene or messier situation than it has to. So just remember, we are the ones that have to stay calm. We're there to help them, not judge them, not get mad at them. Never let your guard down. If restraints are necessary, reassess and document every 5 minutes. Respirations, pulse, motor, and sensation function or sensory functions in all restrained extremities. So we go from, I know it says 5 minutes, but when we're done assessing, we reassess. If we have to use restraints, once again, know your local protocol. Know what your service uses as far as restraints go. Um, if we have to do this, then we are going to continuously be checking the patient and we had better be documenting top-notch documentation. Interventions, uh, diffuse and control a situation. The best treatment may to be a good listener. Intervene only as much as it takes to accomplish a task. If you think pharmacological pharmacological restraint is necessary, request ALS as early as possible. So if we're going to have to knock them down, go ahead and get ALS headed your way as quickly as possible. Uh, but this is what we've been preaching this whole time. Communication documentation, give the receiving facility advanced warning of a behavioral health emergency, document thoroughly and carefully. If restraints are used, say which type they are, um, or what type's being used. Let's see. Psychosis is a state of delusion in which a person is out of touch with reality. It causes are mind altering substances, intense stress, delusional disorders, schizophrenia. Um, okay, yeah, nothing I want to add there. Schizophrenia. So it's a complex disorder that is not easily defined or treated. Typical onset occurs during adulthood, influences thought to contribute brain damage, genetics, psychological or social influences. Symptoms of schizophrenia: delusions, hallucinations, a lack of interest and pleasure, erratic speech. Once again, we do not diagnose. Okay, I can't push that enough. We can think all we want. We can get all of our history and do our vitals and we build a picture. We build a field impression, but we never diagnose these issues. Guidelines dealing with a psychotic patient. Determine if the situation is dangerous first and most off. Uh, let's see. Clear identification. Identify yourself. Be calm, direct, and straightforward. Maintain an emotional distance. So I've been on some of these where it's as simple as, hey, my name is Evan. I'm with EMS, and I will, if I get that trust started and I can see they're kind of pulling away, hey, look, I'm not law enforcement. I'm here to help you. I'm here for you and only you. Sometimes that will get you a little bit of trust by these patients. Um, if they're not dangerous and they're not going to hurt me or themselves, I've actually had officers step out of the truck before just to calm these patients down. So it's a route you might need to take. Guidelines: do not argue with these people. Explain what you would like to do and why. Involve people who the patient trusts, such as family and friends, to gain the patient's cooperation. You're going to run into this a lot, and it's not just for behavioral emergencies. You're going to deal with this because of where we live. And, rural America, we get a lot of stubborn, I will say, individuals who, well, my wife called. I don't really need you guys. The chest pain's fine. Um, use family members. The other thing I really want to push on this one, it says explain what you would like to do. I tell all my classes, we don't study and do this so that we can pass the test. We do this so we can help people and we can save lives when the time needs it. Like when the time comes, we want to know our stuff. Um, so the more we can educate patients on scene, whether it be a behavioral emergency, it be a chest pain, it be a respiratory, it doesn't matter. If we know the material well enough ourselves that we can simplify it to layman terms and educate patients, time and time again, I have seen this work where I can convince people to go ahead and go to the hospital, go ahead and go get checked out because I was able to educate them on what's going on. This is what I think. This is what I'd like to do to you. This is why. This is what's going to happen if you let me help you. This is what's going to happen or could happen if you don't let me help you. So the education side of this is enormous especially when you're dealing with like the behavioral, because if we can talk at their level, instant trust almost every time. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, and delusions. Agitation is characterized by restless or irregular physical activity. Symptoms: hyperactivity, irritational behavior, vivid hallucinations, hypertension, tachycardia, uh, diaphoresis, and dilated pupils. Be calm, supportive, and empathetic. Approach the patient slowly and respect the patient's personal space. Limit physical contact. Do not leave the patient unattended. Um, Once again, read the patient. Adapt yourself into that calming, uh, I don't know, aura or whatever, so that that patient will respect you. That patient will start to trust you. Use careful interviewing. Use careful interviewing to assess the patient's cognitive function, determine the patient's ability to communicate early, observe the patient's appearance, dress, and personal hygiene. Why is that important? So observe that patient's appearance. What do they look like? Are they dirty? Are they clean? Does it appear that they actually usually take care of themselves? Is this an acute onset? Uh, their dress, is it appropriate for for your surroundings. Are we in the dead of winter and they're out there in shorts and a t-shirt? Is it middle of summer and they're walking around in a coat? Hygiene. Once again, are they clean? Are they normally taking care of themselves, or do they look like it's been a while since they had a shower, brushed their teeth? Their appearance, how are they eating? Is their skin dry and flaky and just they don't, it just doesn't look good. Just by looking at someone, we can determine kind of if this is normal for them or if this is an acute onset and something has majorly happened in the last 12 hours. If the patient has overdosed, take all medication bottles or illegal substances to the medical facility, transport the patient to the hospital and use behavioral health facilities, refrain from using lights and sirens. This will agitate them and get them worked up. Um, this says to take illegal substances. I'm calling the LEOs, law enforcement officers, and I'm asking them to take that illegal substance. I'll take the medication bottles all day, but I'm not putting meth in my ambulance. I'm not putting, whatever illegal substance. I'm gonna have law enforcement. I might take a note. I might pull my phone out and even take a picture of the substance, but I am not taking it in my ambulance. If a patient's agitation continues, request ALS assistance so chemical restraints can be considered. Excited delirium can lead to sudden death. So this can be a really big, dangerous thing. Restraints, know your local protocol. So restraints are only used to protect you and the patient. Um, we don't use restraints unless we absolutely have to. Personnel must be properly trained, so know how and when it's appropriate. Once again, protocols, know your protocols. If you restrain a person without authority in a non-emergent situation, you expose yourself to possible lawsuits. That is can be considered assault, battery, false imprisonment, violation of civil rights, sorry. You may use restraints only to protect yourself and others from bodily harm, to prevent the patient from injuring himself or herself. If it's that bad that we are probably using restraints, then we are probably going to have law enforcement on scene. If you question it at all, that's why we have medical control. If you're scared that, oh my God, I can't do that, I'll get sued, I'm not sure what the protocol is, call medical control. Tell them what's going on. They're going to say yes or no to it. Involve law enforcement if the patient is in severe behavioral crisis or behavioral health emergency. Before considering physical restraints, use verbal de-escalation techniques. So that's where we use that nice calming, that slower voice. We don't argue, we don't demand or tell them what we're doing. We ask them, we let them feel like they're controlling the scene, as long as nobody's getting hurt. And we try to keep them as calm as possible. Process to restrain a patient. So carry the decision out quickly. There should be 5 people to help, one on each extremity, one for the head. There should be a team leader and a plan of action. Use the minimum force necessary. So what this is saying is I've got this agitated patient that I'm going to have to restrain. I'm going to get 5 people and I'm going to be like, hey, Bob, you're on the right arm. Bill, left arm, Jan, right leg, and we're going to come to this. Everybody has their own area. And then we are going to, on the count of 3, on the count of 5, whatever, all, I don't want to say attack, but we're all going to make our move at one simultaneous time as quickly and as gently as possible. We take that patient down or whatever we have to do. We got someone at the head protecting the head. You can use the joints to help you. So you put one, like if I'm taking the arm, I'm gonna have one hand on the wrist. I'm gonna put one hand on the back of the arm so they can't bend. Um, but we move as one unit. That way it happens smoothly, safely, and quickly. To restrain that patient, we need to know what time we restrain them and why we restrain them, who was involved and who was on each extremity and head. Level of force will vary depending on these. The degree of force that is necessary to keep the patient from injuring self and others, the patient's sex, size, strength, and mental status, type of abnormal behavior the patient's exhibiting. That's stuff we got to take into account. Um, we have all heard of that superhuman strength people get when they're on certain drugs. It is a real thing, I promise you. I've witnessed it. Best case I can tell you is I had a 48-year-old woman who overdosed. We Narcaned her. She came back. Um, she deadlifted me with one arm off the ground. Like I was in charge of one arm and she's literally like lifting me off the ground. Um, these people have superhuman strength, so keep that in mind. Take that size. This was a 48-year-old woman who probably weighed 140 pounds, but she was lifting me up and I'm 200 pounds and it wasn't phasing her at all. So keep those things in mind when you build that team before we restrain someone. Talk to a patient throughout the process. Treat the patient with dignity and respect. If possible, a provider of the same gender should attend to the patient. Wear appropriate barrier protection. Avoid direct eye contact and respect personal space. Never leave a restrained person unattended. 4-point restraints, both arms, both legs are preferred. Know your local protocols because you cannot just tie them, like cinch them down to that cot. They have to have a certain amount of movement within those restraints. But I think that's per protocol. Talking too much. My coffee's getting cold. Monitor the patient for vomiting, airway obstruction, respiratory status, circulation, or circulatory status. So your blood pressure, changes in level of consciousness. We recheck that AVPU because AVPU is a form of a vital sign. So I've had students ask me, okay, I've got someone restrained and they start vomiting. What do I do? Well, if it's not a traumatic thing and we're on a backboard, we can just simply turn their head, start suctioning, right? Um, so we use a little bit of common sense. It goes a long ways. Violent patients account for only a small percentage of patients undergoing a behavioral crisis. Most of these people, it's going to be more emotional crisis. Um, we look at things from the worst possible scenarios down to the least serious. Most of them are just going to be your emotional patients or your just argumentative patients. The ones that are going to be violent are few and far between, but we still need to be prepared for that. The history has the patient previous exhibited hostility or hostile, um, overly aggressive or violent behavior. So this one's kind of fun to think about. The posture. How is that patient sitting or standing? Is that patient tense, rigid, or sitting on the edge of his or her seat? So earlier I said, that 250 pound, 6'5" guy over there. Just because he's a big dude, does that mean he's a bad guy? Absolutely not. We are looking for, his veins popping out of his forehead. Is he like making a fist and gripping his chair? Or is he standing there all puffed up like he's just ready to tear something up? These are the kind of things we want to watch for. And that might not even be my patient. My patient might be here with me, but someone else in that room, I need to pay attention because that's part of my scene safety. So just keep that in the back of your mind. So the scene is the patient holding or near potential lethal objects. I mentioned a gun on the shelf earlier. The reason I said that is I've been on a call where we go into a home, and I'm standing beside the closet while my partner, I don't even remember what my partner was doing. I kind of glanced behind me at the closet door, and there's a loaded 45 pointing towards me, laying on the counter, just sitting in there on a shelf. And I'm like, oh, okay, that's probably not good. So I just slowly slid the closet door shut and kept about my business. And made sure someone was between me or between the gun and the patient at all times. There was no chance he was going to make it to that closet, but those are the things we got to keep in mind. Scissors, um, nail files, anything that can be a weapon. Not that they're going to use it, but we need to notice those things. Vocal activity. Which kind of speech is the patient using? Loud, obscene, erratic, or bizarre speech patterns usually indicate emotional distress. Read your patient, read your room. Physical activity. Most telling factor of all. A patient requiring careful watching is one who has tense muscles, clenched fists, glaring eyes, is pacing back and forth, can't sit still, is fiercely protecting personal space. A week ago, I went on a code. I had someone in cardiac arrest. We get in, my partner and I begin. We've got the Lucas set up. We intubated. I'm actually at the legs pushing medication. I IO'd a person. I'm pushing epi, and my partner simply asked the family, "Hey, can you guys turn on a few more lights?" And there was a 17-year-old male who absolutely lost it on us and started screaming and yelling and started across the room at my partner. Um, that right there is everything that we've been talking about. Was he a threat? Possibly. Was he high or on medication at that time? No. It was because we're coding his grandpa, um, and his emotions got the best of him. It made him mad because we asked for more lighting and he didn't have more lighting in the home, and it just triggered something. So they don't have to always be drunk or high, or this was a normal 17-year-old kid whose emotions got the best of him. So this is why it's important we read everybody in the room and we're constantly watching. He never did make it to us, in case you were wondering. Other factors to consider: poor impulse control, a history of fancy fighting, uncontrollable temper, history of substance abuse, depression, um, functional disorders. Are the patients always going to be able to tell us any of this? No. Can family, if they're on scene? Absolutely. Can we tell by the way they live, by their hygiene, by the condition of the home? Absolutely. This helps. Um, I know I've said it. Read the room, read the patient. Suicide, depression is the single most significant factor that contributes to suicide. It is common misconception that people who threaten suicide never commit it. Suicide is a cry for help. Someone is in a crisis that he or she cannot handle alone. Immediate intervention is necessary. Uh, I've done a couple other, well, in-person classes. You guys, as you watch my videos or you attend my courses, you will learn. This is a huge one to me. I take this one super personal. Just because they are talking about it or just because they're joking about it doesn't mean that they're not considering it. Take these people serious. Listen to them. Be empathetic. Um, I'm not saying immediately call cops on someone because they say, yeah, sometimes I wish I would just go to sleep and not wake up. But we need to pay attention to these because they can and usually are serious. If they're joking about it or talking about it, it's crossing their minds. Be alert for those warning signs. Uh, Air of tearfulness, sadness, deep despair, and hopelessness. Avoid eye contact, speaking slowly, and projecting a sense of vacancy. They're unable to talk about the future, suggestions of suicide, having any plans related to death. We've got to take it serious. Consider these additional risks. Are are there any unsafe objects nearby? Is the environment unsafe? Is there evidence of self-destruction or behavior? Is there an imminent threat to the patient or others? Additional risk. Is there an underlying medical problem? Are there cultural or religious beliefs promoting suicide? Has there been trauma? And this is death of a loved one, death of a child, loss of a job, divorce, sudden financial problems. A suicidal patient may be homicidal. Well, if I'm going out, I'm taking Joe Blow with me because I don't like that dude. We got to take these people serious. Um, I'm going to get off track for just a minute and tell you in this occupation, pay attention to your coworkers, um, take care of each other because I've said it before, there's things that we see and do and hear that our brains aren't supposed to handle. And this job, along with law enforcement and military and fire, are some of the leading suicides. So pay attention to your partners as well, which takes us right into post-traumatic stress disorder. Returning combat veterans um, are at the top. So PTSD occurs after exposure to an injury from or a traumatic event. Examples: sexual or physical assault, child abuse, serious accidents. We're going to make runs on people that are going to affect us. Examples: natural disasters, war, loss of a loved one, stressful life changes. Um, Anything that happens that we can't actually comprehend, and people will replay them. Sometimes it happens immediately. It will start immediately. Sometimes it might be 10 years down the road, and all of a sudden we just get these floods, or these patients get these floods of this bad event, and that is post-traumatic stress disorder. Not necessarily a result of one event. An estimated 7 to 8% of the general population will experience a form of PTSD at some point in their lives. Military personnel with combat experience have a high incidence. Um, and like I said, EMS, fire, and law enforcement also fall right up there in that high category. Symptoms, they're going to start feeling helplessness, anxiety, anger, fear. You're going to see them distancing. If the family says, they used to be really outgoing, but now they stay in their office with the lights off playing video games, or they don't they used to golf every single Sunday and they haven't golfed in 2 years after that incident. Okay, so that's going to tell me that could be part of that PTSD. It's that anxiety, that fear. So keep those things in mind. People with PTSD frequently avoid reminders of the trauma, loud noises or smells, interactions with people. They suffer constant nervous system arousal, can relive the traumatic event through thoughts, nightmares, and flashbacks. These are absolutely terrible, and it's true. Um, if a family member, if the patient is sharing this with you, don't ask for details. You can't ask, have you seen a therapist? Are you seeing a therapist? Um, but don't ask them to relive that. Uh, some of these, depending on the call, once again, we don't want to run lights and sirens. We need to, well, I'll stop there. We just need to be very vigilant and empathetic on these patients. Combat veterans are prone to early heart disease, higher incidence of type 2 diabetes, loss of brain gray matter, higher incidence of traumatic brain injury. Caring for a combat veteran requires a unique level of understanding. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Um, Respect the veteran's personal space. Limit the number of people involved. Ask about suicidal intentions. Some of these are really hard to talk about with patients, um, but we need that information. Uh, Respect their personal space. This is huge. And this isn't just for veterans. I know that's what it says because they're the highest rate. Um, think before we speak. We need to approach it. We're in charge, but we're also very empathetic. We're there for that person. We might be the only person that actually listens to them. So we need to be good listeners. Ensure that there's nothing the patient can access and use as a weapon. Physical restraints may simply escalate the problem. Yeah, that's very last case. That's the last thing we want to do to anybody. Let's see. Medical legal aspect of EMS are more complicated with patients undergoing behavioral health emergencies. Legal problems are reduced when the patient consents to care, which sometimes can be tricky. You must decide whether the patient needs immediate emergency medical care. The patient may resist your attempt to provide care. Never leave the patient alone. Request law enforcement personnel to handle the patient. Consent. So implied consent is assumed with the patient who is not mentally competent to grant consent. That's why we ask those questions. Where are we at? When's your birthday? How many quarters in a dollar? Um, do you know what's going on? What's your name? If they are unable to answer them, then they're not mentally with it. Consent matters are not always clear cut in behavioral health emergencies. If you are not sure, request the assistance of law enforcement personnel or guidance from medical control. Limited legal authority. The EMT has limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists. Um, Competent adults have the right to refuse care. It's that simple. Sometimes that's really hard for us. I know you need help. This is the problem. This is what's going to happen if you don't let me help you, and they absolutely will not accept your help. That's something we just have to eat. I mean, there's no way around it. Um, Okay, so a psychotic case, a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent. Maintain a high index of suspicion about the patient's condition. Err on the side of treatment and transport. So if they are not competent or uh, you can tell that there is major mental issues going on. One, I'm always going to tell you to call law enforcement. We want to document like no other. Um, and we have got to worry about the treatment and the transport of that patient. Okay, we're about done, guys. A behavioral crisis is most accurately defined as. You can pause this video and answer the question because I'm just gonna kind of cruise on through here. Answer is B. Any reaction to an event that interferes with the patient's activity of daily living. Depression and schizophrenia are examples of depression and schizophrenia, obsessive compulsive disorder, and bipolar disorder are examples of functional disorders. When assessing a patient with a behavioral crisis, your primary concern must be D. There's many things that you should be considering, but mainly we want to make sure that ourselves and our partner are safe. General guidelines to follow when caring for a patient with a behavioral crisis include all the following except. Okay, that's going to be B. Rapid transporting the patient. That's not one of our general guidelines. Reflective listening, an assessment technique used when caring for patients with an emotional crisis, involves going to be D, reflective listening, a technique in which you repeat in question form what the patient is telling you. Allow the patient to further expand on his or her thoughts. It also helps the EMT gain insight into the patient's situation. It also makes them feel like you care and that you are paying attention to them. Which of the following patients is at highest risk for suicide? Yep. See, so all of these, so A and B, they got pretty good news. D got good news. C though, drinks a lot, which adds to depression and actually makes it worse. Um, and he just purchased a new gun. So this guy, he's kind of a code red. We're watching him really close. When caring for a patient with an emotional crisis who is calm and not in need of immediate emergency care, your best course of action is to just because the patient is experiencing an emotional crisis does not mean that he or she is mentally incompetent and cannot refuse EMS treatment or transport. You should attempt to obtain consent from the conscious patient unless he or she is clearly does not have decision-making capacity. So there you go. These are the people where that education we talked about, being able to talk to them at their level, but using your knowledge will come in very handy. When physically restraining a violent patient, the EMT should. Okay. Yeah, A, definitely. We need to talk to these people, talk to the patient as he or she is being restrained, try to keep them calm, explain that they are endangering themselves and others, and that these are the steps that have to be taken. But we don't yell at them, we don't scream at them, we stay calm while we're discussing this with them. Upon arrival at a residence of a young male with uh, emotional crisis, the police officer tells you that the man is acting bizarrely. You find him sitting on his porch. He is conscious but confused. He takes medications but cannot remember why. His skin is pale and diaphoretic, and he has noticeable tremors to his hands. You should first rule out. Yeah, very first thing we're going to go ahead and we need to rule out hypoglycemia. So we need to get that sugar checked because we have altered mental status. We're pale and diaphoretic. So we're kind of in a phase of shock there. Um, we need to knock that out first. Ooh, takes medications. Um, my first thought when I read this was possible DTs. So I would definitely want to know if he drinks alcohol or if he has stopped recently. But pale diaphragmatic skin, altered mental status. Definitely we need to check blood sugar first. Which of the following signs is least indicative of a patient's potential for violence? I'm glad I gave the example I did. So A, C, and D, these are all things that we see that patient doing and that kind of gives us indication that they're unhappy. Just because that person's 6'5" and weighs 230 does not mean they're violent. Might be the biggest teddy bear you ever met. So B. All right. So guys, we made it through chapter 23. Thank you for sticking with me. I will catch you on the next one.